I have a friend in the military, and I know I'm like, I have no idea what that means.
Told her to do a 101.
Or 50-50, you know, 101 is there, and after that.
After that.
Do a 50.
50.5.
Just keep an eye on me if my eyes start going like this. Going too hard.
Bring it down a little bit.
Hours. Okay, welcome to the February 11th, 2022 work session. It's the self-funded health insurance plan overview. The work session is open to the public. There will be no public comments or questions taken. And depending on Darren and Diana, if you guys want to take questions at the end of each of your sessions, or do you want to take them during?
I'm open to either. Darren, do you have a,
I think during would be best.
okay?
Okay, well, let's start this thing out. We have an introduction by Darren House, our Human Resources Director.
Good afternoon, all. Darren Hass, HR Director, City of Cheyenne. What we want to do today is, as you know, the city's been trying to position ourselves the last 2-3 years, probably longer, to possibly go self-funded on our insurance, medical insurance, versus the staying fully funded, which is what we are today. So we've invited Novo, who've been our benefit consultants now 4 years, to do a fantastic job, and they're going to do a presentation to kind of show us the difference, self-funded versus fully funded. There is some risks involved, but there's also a huge potential for financial savings too. So we'd like to kind of hear a little bit more. Where we are last year, we weren't quite ready for it. We have a funding, we have a trust account, we have the financial backing ready to go, but the timing wasn't quite right. We had COVID in place, but now we want to look at this year. Is this the year we can flip that switch? So kind of introduce Diana Madvig and Kelly Grady with Novo Benefits, and Diana, we'll kind of let you.
Well, thank you for having us in here today to talk about the self-funding model. Really, self-funding is, on the surface, it's a very simple process. In the background, it's kind of like looking behind the blanket wall of surgery. But what you guys, or what the employees would see in the city, would be the plan would run very similar to exactly like it does today. On the self-funding, we see, can you go to our next slide, please? So we have fully insured, which is what the city has been fully insured now for, I'm going to say, probably pretty darn close to 15 years. And that model has worked very effectively. We're looking at going self-funded.
I'm sorry that you can't see Diana, but because I'm sharing my screen, my camera doesn't work. I can't share screen and use the camera at the same time. That's why I can't see her. My screen is screen sharing, that's the PowerPoint, so the camera. Sorry, Diana.
No worries, my friend. I could have come in jeans and a t-shirt.
I mean, I guess it is.
So if we flip to the next tab down now.
Another one?
Yep. Then we'll go to administrative services only. And that is going to be the selection that we go with on a hybrid model of that. And when it says that little administrative services only piece, you guys, that is when we're using a fully insured insurance company to administer our plan. So we're going in and saying we want to utilize the Blue Cross and Blue Shield network because that gives us the deepest discount on our claims and the highest provider base in Laramie County and the highest chance that we can control costs. So as a result, we'll use the administrative services only, a contract, and then we're gonna take that and hybrid that out even more, if you can. So when we look at TPA services, that means third-party administrator. So in English, you guys, who's writing the checks for the healthcare plan? Who is going in and looking at our plan document and saying, we have XYZ, that claim is within our plan document, and Blue Cross is the carrier that will write that check for us. And when we look at vertical integration in insurance companies, in English, it just means that the TPA, or the third-party administrator, owns a lot of the different components and manages those within the healthcare plan. And we specialize in trying to break as much of that caveat, or I should say profit, away from the insurance company and the administrator so that we can keep that money back in control of the city. So if you'll click one more time, please. And we go in and do what's called a TPA unbundle. And look at all those crazy little bubbles, and we'll talk about those in a little bit more detail. But when we unbundle,
I'm confused. They say the slide isn't, progressing, so you guys can't see, what are you seeing? Are you seeing 4 icons on the slide right now?
No. Hi, Jen. It's Jeff. All we are seeing on Zoom is the City of Cheyenne self-funding slide. So I've got the presentation that you emailed us back on February 3rd. So I'm going through it manually along as Diana is speaking, but on the Zoom side, it's not progressing at all.
Okay, hold on just a minute. I have never shared my screen. I'm not used to doing this, so I don't know. Maybe I'm doing something wrong.
I doubt that.
I'm just closing all of these. I'm gonna open this PowerPoint. We want to view it as a slideshow, right? I can just share my. Or this one. Or this one. I mean, this is the PowerPoint. This says PowerPoint right here, which I think is what I had up before.
Now I've got the slide with the 4 icons. So I think you're set.
Jeff, I helped.
Also helps if you hit the enable editing button at the top, usually.
I doubt that, Scott, but we'll go with it.
Does everybody have the 4 icons now?
Yes.
I gotta do this.
Okay, you're fine.
I don't think that I'm gonna be able to do like how each one pops up
That's
separately,
okay.
So
Yep,
it'll
that's
just be
fine.
each
Yep.
thing, okay. So you wanna go to the next slide, Diane, or you
Yes,
or
please.
Christina?
Are you then on slide 3?
Yeah, slide
Okay.
3 now.
Yes.
Perfect. So get into the real nitty-gritty of what the difference is and look at it. On the left side, it says, talks about fully insured. So really, we have our renewal based on the carrier's pool and the claim experience for the group. So not only do we need to have the City of Cheyenne run really well to get a good renewal, but we need to have Blue Cross's entire block of business run very well as well to get a decent renewal. Then we need plan design, and that's a frustrating thing when we're fully insured because the plans have to be filed with Center for Medicare Services, with the Department of Insurance, and so forth. When we're self-funded, we get to control our plan design, and we get to, remember, 4 years ago, the city used to have 2 different plan designs, and we had to surrender one of them because it cost us 3% to add the second plan, and I think we only had like 30 employees on that plan. It was a really low number. So the frustration of not being flexible in the plan design is also a big frustration on self-funded. And when the city of Cheyenne went fully insured with Blue Cross and Blue Shield, we had them build us a custom plan design because the city, the county, and the Board of Public Utilities all went fully insured with Blue Cross at the same time. And we created a very workable plan design that gave the employees good benefits, as well as really nice, affordable doctor co-pays and drug co-pays. So fully insured, we lose a little of that flexibility. Traditionally, Blue Cross does not do a copay unless the deductible is in excess of $2,500. Yeah. So we thought that would be too big a burden on the employees, a catastrophically high deductible when we could avoid it. So we did some things. Fully insured restricts what we're doing on our plan design considerably. The provider network is really determined by the carrier. In this case, we're using the Blue Cross and Blue Shield network. When we're looking at changes, employees, every single time we go out and get a fully insured quote, we have to be able to give that carrier information because it has to go through a full and robust underwriting system. So if we were to go back and get a fully insured quote from the majority of carriers and not have them build in a cushion for high claim risk, we're going to end up paying a higher premium for that, or the employees are going to, all 439 of them, Darren, are going to do an application. And that is a painful process for that many employees. And it's difficult for the employee. They have to fill out an application questioning medical information, drugs they're utilizing, what's happening with them on every single person on their health care plan. And we're trying to get away from a little of that disruption. When we go on the self-funded side, the city actually becomes its own little mini insurance company. And when we do, then our renewal base is going to be affected based upon our own claim performance. And through that claim performance, that gives us a better opportunity to tweak and adjust the plan to help control and keep the group as healthy as possible. So we get to determine what our plan designs are. We can actually add a second plan design or even a third plan design without having to pay that 2% higher premium on the entire piece, because that can be very expensive. When the employer, all of the contracts sit within the city, so the city of Cheyenne would have contracts directly with Blue Cross and Blue Shield. They would utilize the contract that Blue Cross and Blue Shield has directly with Prime Therapeutics, which is the drug card inside of your health care plan. And then we have advantages of the city managing and seeing that contract. Then because we're really building our own insurance company, so to speak, we will have a stop loss and an aggregate policy that we'll talk about in more detail in a few minutes. And those contracts will sit directly with the city, and the city will be able to see exactly what that contract says and own it and control that contract. When we do any changes within the plan, we do that within the rules of whatever TPA, third-party administrator we're using, or whatever network regulations that we're using. And that's something that Kelly and I and those of us on the Novo team are very careful to keep a really tight rein on to make sure that we're staying in compliance with that. On slide 4 now, the pricing of it is a little bit different, right? And you look on the fully insured side, and it's kind of a nice color graph, so I tossed that one in because you guys could look at it and see fully insured, look at what your claims are, is the green bucket. Then we have mandated benefits that are mandated. For example, remember when the Affordable Care Act came into play, and we had to, if you were non-grandfathered, we had to open up preventative to 100%. And when we did, there's certain mandated benefits like that that we need to do. And when we do those are mandated benefits inside of it. It's really, most of them have not been a hardship, but actually a positive thing for most of our groups. And we see those mandated benefits could be a state mandate that when we're self-funded, we don't have to manage the state mandates the same way just federal mandates. Then we have our administration. Then we have our premium tax. So every single year, we pay a 3% premium tax on every single penny that the city gives to Blue Cross and Blue Shield. And the state gets a 3% premium tax on that. When we go self-funded, we only pay premium tax on that tiny piece of the stop loss and the tiny bit of the aggregate premium. So, and then Blue Cross has profit. If they don't make a profit, they go out of business, and we've been down that road with Win Health a few years ago, right? When we go with a self-funded, unbundled model, we're really going in and cleaning it out and saying we have a lot more advantage to capture our savings. We have a much higher advantage for managing our network, managing what administrator that we select and use, and then we go in and build in our stop loss and then our aggregate premium also. So, slide 5. So when we go in, think about it now. You have your deductible for an individual person, but when we go self-funded, we're going to create a massive deductible. So let's say, for example, our specific, which is our reinsurance, we're going to go in and say any claim under a hypothetical number, any claim under $125,000, the city pays for immediately. When we hit over on a single claim for each individual member, so that could be an employee, it could be a spouse, or it could be a dependent, when we have any claim that happens that exceeds that $125,000, then that reinsurance or the stop-loss carrier picks that claim up and takes over from then on through that contract period. And that is what gives us the protection to be able to say, we know what we can manage on our risk here below that envelope, and we can safely do that. And by doing it, we allow those claims to go in and get paid anything over $125,000. But then we have our next bucket, which is, on our next slide, please, our aggregate premium. And our aggregate premium takes all those claims under the $125,000 and rolls them into a big bucket. And then we have our, guess what? We hit a worldwide pandemic, and our plan hit maxed out. And when we did, our aggregate premium says, this is what our walk out the door number is for the year. And if we should have something happen and hit that number in a single year, it's a super low chance that it happens, but if it does, we have a premium to pick up and carry the cost of that so that the city doesn't have to go beyond its budget. So when we build our budget plan, we know exactly what that number is on our aggregate premium. Then we go in and fund into it, and then we build in our calculations of the premium. So our next slide, please. So when we look at a superior model, it's to really go in and look at some of the details of our little mini insurance company that we're building. Notice in the middle, the city of Cheyenne is in the middle because you guys are the insurance company. And the people inside the trust can make great decisions inside of it. And then through Novo Benefits, we go back and make sure that all the components that we're utilizing are working to the advantage of the plan and working so that we have benefits that are readily available to the members whenever they need care, and also have a network wide enough that you guys can utilize that efficiently. So we look at the top, our little orange bubble, the third-party administrator. Remember, that's Blue Cross, so we don't have a big change in disruption. Then we look at the stop loss. Are you ready for this? We have very few limited coverage. We have less than a handful of carriers that will come into the state of Wyoming and write a fully insured group. And if you're a true believer in capitalism, we can't walk in there with 3 quotes and really get aggressive on a decent shop. Our hands are tied. But Novo Benefits, the reason we have specialized and been so successful in self-funding with our groups is we have our entire underwriting department, and we actually go in and shop it out with 32 stop-loss carriers every single year. And the nice part is, if we make a decision to leave one stop-loss carrier and go to another carrier, the employee sees zero disruption in that. So your ID card stays the same, your prescription card stays the same, your doctors and hospitals that you go to all stay the same, and we can change and get the most expensive part of your fixed cost in your plan and take that out to bid every single year without having any disruption. And our next bubble is really talking about prescription benefit management. That is your drug card. So when you guys are going out right now and you're utilizing your drug card, and whether you go to Osco Pharmacy or Walgreens or Walmart, your drug card needs to be someplace that you can use it efficiently. And we need that pharmacy benefit manager to be fair with us, to give any rebates back into the plan, because you legally you guys should own those rebates. So we make sure through our vetting processes that Prime offers all of those rebates come back into the city. And it won't be an uncommon thing for a group your size to receive anywhere from $250,000 to $400,000 a year back in rebates. Now, Blue Cross will tell you when they build their fully insured rates and they go back in on the fully insured side of it, Blue Cross is going to say, we gave you a credit for your rebate. And I go, but the rebates were credited to the entire block of business. It wasn't just credited and focused on what we did here. So if we do really good drug management and we're able to reduce some of our expensive medication and get it moved from a brand drug safely over to a generic drug, the city should save that money. And that's the advantage of being able to do that. And we keep Prime in check and we vet those contracts out exclusively to make sure that all the rebates are coming back to the city. Robin will be getting a check on that, and usually it's like 6 weeks, followed by the next quarter after that. So 9 months or so before you start to see your first check. And then after that, it'll be every quarter, okay? Ironically, the cost of us borrowing or leasing Blue Cross and Blue Shield is almost paid for entirely every time by what we make back in rebates. So it really comes out as a nice net neutral. The next bubble is the Ppo Network. We don't want to go out and build our own darn network, right? It's too complicated. We want to make sure that if we have an employee on vacation in Anaheim, California, that they can go into an in-network hospital facility or an in-network provider. And that's one of the big advantages of the BUCAs, meaning Blue Cross, United, and Cigna, is they have a vast network, and we're going to get a good discount, and that gives the employees a high chance that they're going to go in-network, have that claim be paid affordably, and not have to pay an out-of-network deductible. The next is telemedicine. Through COVID in the last 3 years, telemedicine has changed dramatically. I don't know, my doctor is with UC Health. I can do a Skype doctor's appointment with UC Health. CRMG, the Cheyenne Regional Medical Center group, their docs can now do telemedicine appointments. I think they're, Darren, isn't it Monday through Friday until 10 o'clock at night? And I think they even added some on Saturday or something. And you can do that off of your smartphone, off of your computer, and never have to go in and battle the urgent care or, worse yet, battle the ER. So telemedicine, because of COVID, actually was a huge caveat. And I know the first time I ever put it in with the group, you guys, 14 years ago, the drugstores wouldn't fill the prescriptions. They'd send it in, and they're like, I don't know that doc. I'm not filling it. And we really had to battle through that issue at the beginning many years ago. And now we're taking them hands-on, and it's made it much more efficient. Cost containment tools. Workers Partner is it's a disease management company that is actually plugged in to our City of Cheyenne fully insured book right now. And they manage some of our highest risk claims, and they go in and help that employee actually get information from their doctor when they need it. They help, these are master's degree nurses, they help go in and do some coaching. So that's gonna be a piece that we go back to the insurance committee to talk about whether we add that cost containment tool into it. Care coordination is another model that works really efficiently as an add-on to a self-funded plan. So our next bubble is our utilization care bubble and disease management bubble. We can go in and add external components and plug them in and overlay them into the Blue Cross and Blue Shield system and do that. So we have a lot more flexibility to help support and then also help move forward and keep the employees as healthy as possible. Our next bubble is transparency tools, and we actually have data software systems that we can go in and data mine into your claims pool so that we literally can say, we have 79 people that are diabetic in the city's group. And out of that 79 people, we have 42 of those people that are not drug compliant. So what could we do inside the plan to help incentivize those employees and help make it easier for them to get the medication that they need, to be able to do their blood tests as frequently as they are necessary, so that we can help whenever we see an issue like that, when we're self-funded, we can build the plan up so that we can help tweak it to help support that. And I'm going to give you an example. I had a hospital, and we had some of the lower income people in that hospital group that were diabetic, and they couldn't afford their test strips. And that was catastrophic because these people were on a path to end up going into end-stage renal failure if we didn't get control of that. So we were able to go into the plan and say, okay, if you're diabetic, the test strips are free. We'll cover this, this, and this. So we have a lot of caveat inside of it if we see that we have a high-risk issue, that we could put a little bit more money into it to help the employee and support them on that need. So those are some of the things. I know Darren has been working a lot on working on a wellness program, and that wellness program can also quasi-plug into this model as well. So, next slide. Building a sustainable self-funded plan. That is the million-dollar slide, everybody. It takes a lot of commitment to the concept, and that concept sometimes can be scary. We've all heard of groups that have gone self-funded. They didn't really understand it well. They didn't fund their program as if it was a fully insured program until they built reserves up, and they got into trouble, and by year 2 they imploded, or sometimes year 5 and they implode. It's very critical that each year that we all, I can tell you that we do, Darren does, Robin does, the city, we have a fiduciary responsibility to keep that plan solvent and keep that plan safe. And as a result of that, that is probably the biggest thing. We have to be very dedicated to that and committed to it, that when we look at it and say, gosh, we know that this year we could go in at XYZ rate, but we're still building our reserve, so we need to build that reserve up. And we don't need to build it by saying, gosh, Mayor, if you could give us $20 million, we'll never have to worry about this again, because the city would say, no, that's not happening. But if we were to go in and say, here we are in our fully insured premium on what our renewal looked like, here's what we anticipate that to be, but we know we still need to fund reserves for a couple of years, so we bump what our funding is a little bit until we find that number that A, is tolerable, and B, is going to help us continue to slowly build that reserve up. We have to be very committed to that and watch what a reserve is. We also...
And how big does a reserve need to be for a city our size, 600 employees? What do we need?
I know, it's $1 million question, Mayor, and a great question. It's all relative. We kind of, on our side, if we, as a government entity, we get to reserve more without paying taxes. That gives us a lot more caveat to be able to go in there. I am very conservative because I've seen plans have a blow-up year and make the decision to not adjust their funding or not have enough reserve in it. It's not if we look at a cycle of 5 years, out of 5 years, we're going to have years where we run in at 60%. We're going to have years that we run in at 75%. We're gonna have a year that we run at 87%, and we take that high and low average. I like to conservatively say that we're gonna run close to 9 months of whatever our claims bucket is when we finally get to that claim side. And we can go out and do an actuarial study with that, because we work with in fact, the people that started self-funding in the country 30 years ago. We actually work with Phil's number one guy. And as a result, that has given us a lot of additional insight into it. I like to look at 9 months, but if we really started into it, we could say a lot of actuaries would say 2 months worth of claims, 2 months worth of fixed costs, $250,000 for lasers that occur per 500 belly buttons. So you guys would then look at it that way, and then it would allow us to put together that number. It's still going to be lower than 6 months, but 6 to 9 months is going to be a nice cushion that would keep the plan very stable.
What is 9 months?
You guys spent $6.6 million in claims last year. We paid $8.6 million. So I think we're on track to probably close to $8 million that we're going to pay in premiums this year.
$6 million reserve is kind of what.
Correct. And, you know, we have a pretty good start. Robin has been very astute in the committee in the council about really keeping tight on that, so that we had a bit of a start with it. So that's one thing. Monitor our performance constantly. I can tell you we're very OCD about making sure that we keep an eye on what's happening with the plan, and we have a very tight relationship with Blue Cross too. We can literally go in and see pretty much everything that happens inside of your plan. We have to be very systematic in our benefits and very systematic in our cost control, so that we're not throwing money away because of one single piece, but we're being very good stewards of the dollar, so that we can keep our insurance company solvent, so we don't have what happened to Win Health. The next thing, I always laugh about this, don't panic, right? It's scary. It's scary for council people the first time a group goes self-funded. And the real trick to it is to always know that we're funding to the number that we know is going to get us out the door, and that we always have enough money in reserve, that if we made the decision 5 years into it, we're not going to do it anymore, that we just turn the key, we have enough money to let the claim run out manage, pay our fixed costs to run out, and then we walk away from the whole thing and go back fully insured. So our next slide talks about what do we do, and I promise I will not run through every single line item on this, because remember when I said looking behind the curtain, it's a little bit scary? There's a lot of compliance stuff that we do on our side that Darren has to watch on his side, and that Robin takes care of on her side, so that we're all making sure that claims are getting paid. We know Blue Cross is doing their job and getting claims processed. We know that we're managing still in the best network for our advantage and so forth. But things that we do and watch for: compliance and regulatory changes. We manage through our broker services, the plethora and the big bubble screen. Then we also turn around and look at underwriting. Our advantage on underwriting of being able to utilize 32 stop-loss carriers each year is huge for us to keep our stop-loss and our aggregate premium under control. We specialize in vendor management when we plug an extra component into the healthcare plan, because we think it gives us a caveat that helps us, or it helps us with management of something. Then we're very careful on the vendor selection, and we vet those out very carefully before we plug them in. And then we work with Blue Cross to cover that piece and put it together so the employees don't feel a bump in it. Our next thing is data analytics. On our side, and what the Employee Benefit Committee will see, is a little more data inside of it, because we're self-funded, we own our insurance company, and we need to be able to go in and see what's happening on claims. And I want everybody to know, just because we see it doesn't mean that we single out and say, Darren Haas has high blood pressure and his cholesterol is out of control. We can't do that. But we could go in and see the metric numbers of that. So keep in mind that this is very much PHI scrubbed. The only people sitting in this room that will ever know that would be Kelly and myself. And as a result, the employees know that their privacy is still going to be protected. Their health information is still heavily protected inside of it, the same way it is now. The next thing is population management. We will be working and set a path up and really talk a lot about what our 2-year goals are, what our 4-year goals are, so that we know long-term what our path is. If our path is to be able to say, we'd love to be able to put enough financial incentive into it in a wellness program that we incentivize the employees to make great choices and work to stay as healthy as possible. And in doing that, our wellness program is going to incentivize the employees with a reduction of premium or money back, however the city makes that decision. But by doing that, we need to be able to make sure analytically that what we see inside of the population is giving us a reaction that's making the money worth it, right? Because we all have that fiduciary responsibility with it. And our next one is the end. And I say that because if somebody has questions, you see my cell phone number, my email, as well as Kelly's cell phone number and Kelly's email address. If somebody has a question, please feel free to reach out to us, send us an email. If someone on the city council would like to sit down with us on a one-on-one over a cup of coffee and talk in more detail, we want you guys to know that we're very accessible. Our office is just right over here, and we're in town.
Any questions from committee?
Mr. President, this is Jeff. I have a question. Question, this either goes to either Diana or Robin. You know, going self-funded has been a goal ever since it's been discussed for the last 6 years. And, you know, the one thing preventing us, well, one of the biggest things from preventing us from going this route was the lack of money that we had in reserves. And you kind of talked a little bit about that, Diana. So either Robin or Diana, I mean, we've made a great deal of progress over the last couple of years in increasing the amount of our reserves. In your expertise, or do you think we are now in a position to make that leap, I guess is what I'm trying to say. And then also, you know, we're seeing healthcare coverage increase exponentially, really not unexpected considering the pandemic and the stress that that's put on the healthcare system. You know, does that provide a cautionary table of going this route at this point in time?
That is a wonderful question. I'm glad you asked it. You know, last year we had great numbers to go self-funding. We really did. And I can tell you on Novo's side, we talked about it a lot. Talked with Darren, talked with Robin, and said, you know, I think we should kick the can one more year because of the pandemic, and it had nothing to do with anything other than if we were to blow up, I would have rather blow up and have that be on Blue Cross's dime than the city's on our first year self-funding. The amount of money that we have in reserve right now, plus the amount of money when we're funding correctly in the first quarter of the new contract cycle, is going to give us a fairly decent reserve. When the county went self-funding almost 3 years ago, we had money earmarked and we never used it. And the county right now, they're smaller than you guys, but they're sitting with like $2.7 million in their reserve, and we started with nothing. They earmarked money. They said if we need it, we'll use it. We were careful on what our premium budgeting was when we put together our numbers, and that falls on us to be able to say, okay, this is the funding number that we have to stick to. And I can tell you that if we would have had any problem with the commissioner saying, hey, we're not going to take that advice, we're going to do our own funding and pay as you go, we would have said, nope, we're done, we're out, because it's that critical in the funding strategy of it. And we've never, I know when we've had internal discussions for the last 2.5 years about being able to go self-funded, because we've tried hard to do that the first year, it was cheaper to stay with Blue Cross. The second year, it's been kind of fun because Blue Cross has to match whatever the self-funded world comes out with in our renewal rate, fully insured. And as a result, we've been able to go in and kind of box in Blue Cross and keep them honest, and they've done a really fair job. And what do you do when they come back and say, you know what, we're going to give you, last year we had a 0% increase, then we're going to go in this year and just give you a pass on that contract. And we even had, 1 month's premium waived. So Blue Cross has been working really hard on their behalf to keep you guys fully insured. And last year we would have, have that number for last year, Kelly? We have. I think the delta last between what you guys paid in claims and what you paid in premium was close to $2 million. Now, Blue Cross would have profit, they're allowed to take into that, but we still have $2 million on the table. So I think with us really being careful and thoughtful about our funding on our premium, that we're going to be perfectly fine with that, with what you guys have in reserve right now, and knowing that our first quarter will be really low in claims.
And, Councilman White, I'd like to add, we do have 1.4 million right now.
All right. Well, thank you. And Diana, if I have any further questions, I'll contact you directly. But, you know, I was on council when we hired Novo several years ago, and you guys have certainly been worth your weight in gold. You've really provided a lot of great guidance to the city, I believe, over the last 3-4 years. So thank you.
Well, thank you. We appreciate that and really enjoy working with the city.
Any further questions or comments from the committee?
Mr. President, this is Councilman Seagrave.
Seagrave.
Yes, sir, through you. We're in a period right now of not only COVID, but some would call it hyperinflation. How will that impact us if we do choose to go self-funded?
Well, you guys have had great questions today. We think we are seeing the market hard. We think that because of the change in what's happening with COVID, because when this first hit, and then in particular when the Delta variant hit us, we saw, horrifyingly enough, when people got in the hospital, we had huge claims, but they were small time periods. And right now, Omicron is changing what's happening with hospitalization. Now we're seeing large claims happen because of the long duration. And it's interesting to go in and watch what Cheyenne Regional Medical Center posts every single week to say, you know, they've had people that have hit, 2 months in the hospital. And that duration of it, if we were to have that happen, we'd go in and blow right past and into our specific level up above. So we'd owe $125,000 on a claim like that, and then after that it would go to the reinsurance carrier, and then we wait to see what happens long term. I think in Wyoming that has impacted us because of the length of the stay in some of our groups, and we're seeing it happen more frequently with long-term claims with it. That's causing a hardening of the market, and we're going to feel that and see it even when we go fully insured, right? We'll ask Blue Cross to give us our fully insured renewal rate. They made a commitment to give us PHI protected information to help us go self-funded with the shop when we originally hired them 3 years ago. And they've stuck to that commitment. We always want more than they're going to give us, and we always battle through that. But we also know that they're going to go in and carefully underwrite that, knowing they have to beat what's happening in the marketplace. And that has been a nice advantage for us. Last year, we could have saved money and gone self-funded, but I gotta tell you, I was immediately going, as much as I want to, as much as financially it makes an incentive, what if, right? And in our industry, we've always talked about, well, if we had a worldwide pandemic, how would it affect the self-funding world and the insurance world? Well, here we are, right in the middle of it.
It's never a funny joke,
Yeah, it's not a joke anymore. Now we sit there and go, holy mackerel, and look at how it's affected it. None of us would have ever guessed that it would have meant we shut everything else off and only managed COVID and critical access. And as a result, we actually saw claims decrease, and we have groups right now, you know, we're getting ready for all of our 7/1 renewals, and we have a large block of government entities that all renew on 7/1. And when we're going into those renewals, we have groups right now running in their 40s and 50%. And when we do our underwriting, the underwriters are going to anticipate you run at 80%, and we're going to push the funding budget above that a little bit to give us that protection to build the reserve. But the stop-loss market will harden, and we'll see the impact of the higher claims utilization, but we'll see that also on the fully insured side as well.
And how about inflation impacting this?
We're going to see medical inflation trend hit every single year, and every single year that we have inflation, medical inflation in Wyoming has hit anywhere between 7 to 9% at a minimum. Some years we've had it hit as high as 12%. And part of that is not just medical inflation. Part of it is new medication that's coming out in the marketplace that we want to keep in the healthcare plan. Part of it is the expansion of what's happening inside of healthcare. So, yeah, I think we're going to have it whether we stay fully insured or whether we go self-funded. It's still going to stay the same number.
Any further follow-up questions?
This is Dr. Aldrich. I have a question.
Aldrich?
Chairman Roybal, through you, I'm just curious, and you may have said this and I may have missed it, but for employees that have pre-existing conditions, will there be any waiting period for those pre-existing conditions, as there are sometimes when you change insurance companies?
A super question. None. And the Affordable Care Act really took that away. So even, you know, it used to be if you had coverage in place, went into a group plan years ago, we could do some exclusion if they didn't have coverage, but we didn't see that happen in many group plans. But through the Affordable Care Act, even if we had an employee that had not had coverage for a few years, they came onto the city's health care plan, it would be picked up immediately. And the same thing if we had somebody that left the plan and instead of taking COBRA, they bought insurance through the exchange, they would be covered to reverse and go back out as well.
Thank you, and thank you to Treasurer Lockman. I think that this is evidence of her hard work and diligence, and I appreciate your time and information today.
Any further questions or comments from the committee?
Diana, one question I have is, you know, a lot of people have not their regular checkups and stuff because of COVID. Do we see a bump coming that would concern us with, you know, breast cancers and different things like that, that people haven't been getting checked, that could be a risk to us?
Great question again. We're going to see some of that. Last year, Sun Life, which is one of the largest reinsurance companies in the world, Sun Life said they had a 7% decrease in cancer diagnoses. So we all know what that means. It doesn't mean that 7% less of us got cancer. It means that we have that hanging out over our head a little bit. This year, we're starting to see more clinics that have been more proactive in reaching out to us. I don't know about you guys, but my doctor calls and says, hey, you need to get down in here, right? But we didn't see that 2 years ago. Darn it, I got exposed to COVID right in the middle of the Mullen fire, and I have asthma. I honestly thought I'd end up in the ER before I could get someone to give me an inhaler. Right? They said, well, you've been exposed, you can't come in. I'm like, I don't have a fever, I have asthma, right? I mean, it was inconvenient, but to this last year, we've seen that change where clinics have figured out how to get people in a little bit more. So I'm hoping this year we start to see that change, and then we're gonna have to wait to see what happens on the impact of it. Because waiting 2 years on a potential breast cancer claim could take somebody from stage 1 to stage 3, or even stage 4. So there could be that impact to it, but we're gonna see that impact hit us whether we're fully insured or self-funded.
Other questions or comments from committee? And I have one. Here we are, February 11th, Friday.
Uh-huh,
We renew on July 1st, right?
correct.
We have the things in place to say, yes, we want to self-insure and be ready to go by July 1st.
We do, that's a super question. Robin has been keeping us and keeping her date right on top of us nonstop. To say, okay, this is when I need it, this is when we need to get it in front of the city council and stuff. We have a lot of government entities, so we really understand you guys' timeline, what you need to do on your side on that decision-making process. And even when we go back in and start to get numbers, if anyone in the city council, you guys keep my email, my number is my cell, so you can call me or text me and say, hey, I want to go sit down and have a cup of coffee with you. And then we can talk about it in more detail leading into it, because I want you guys to understand it and be comfortable with it. And if you have further questions that you think of tonight at 2 a.m., then don't hesitate to reach out.
And as a council, and as a governing body, mayor and council, what would be our drop dead date to say, yes, let's do this, so we would have, everything would be in place?
Yes?
I hired an attorney to develop a trust, so we have a trust paperwork ready to go and a resolution. And I have provided that to Stephanie, and she's gonna review it. I want that done by April 1st, and then we'll have it through the council process and
Okay, any further questions or comments from committee? Are there any closing comments?
Sir, appreciate all the work everybody's done to get us to this.
Okay, with no further questions or comments, we are adjourned. Thank you for coming.